What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
What's up, everyone? Dr. Zach Baker of R2P here on the Strength and Knowledge Podcast, and I've got with me today Bami Adu, one of our 2 sports residents, and we are going to dive into our January journal article review. And Bami, it's hard to believe, man. January, we're in month 5 of the residency. Do you feel like you're finally settling into some sort of a routine on a week-to-week basis?
Yeah, just about. Can't believe it's already January. Wow.
It's wild. I think the cool thing is, journal article reviews are one of the many things that we do in residency, the other being community involvement. And on the back half, we're going to be going back out to some of these places we went to in the beginning of the residency. So we're going back out to Oakdale and Linganore High School. We'll be going back out to the Naval Academy, PFP, one of the local strength and conditioning companies in the area. And that is when you and Christian get to take lead on those days when we go out there. So I'm looking forward going into months 6 through 13 with seeing you guys take a little bit more lead on some of these community outreach. And I'm excited with the transition that we've made with our in-services with these journal article reviews of doing these podcast recordings. And I think it's been well received by the staff, and hopefully this is a way for people outside of our staff to benefit from these articles as well. So, Bami, do you mind talking a little bit about the article that you picked for the month of January, which for those listening, we cover the hip in our sports residency this month. But what article did you pick, and why did you think it would be an interesting one?
Yeah, so the article I chose was pain-free versus pain threshold rehabilitation following acute hamstring strain injury. And I'm personally excited about this article choice. I personally struggled with a lot of hamstring injuries playing soccer growing up, so I was always kind of been drawn to more so hamstring injuries. But the cool thing about this article is it talks about hamstring rehabilitation, and it talks about when is there too much pain and when is it safe for us to progress our patients with a certain pain threshold. I think after reading this article, we'll start to see that in rehab, it's okay to have some kind of pain in order to progress our patients. And like any clinician that's dealing with athletes, our number one goal is to get our athletes back as safe as possible, as soon as possible. And this article does a good job of showing us how we could do that while maintaining a certain pain threshold.
Awesome. I'm excited to hear about this article. I don't think I ever actually ran or moved fast enough to experience a hamstring strain, so I can't speak to too much personal experience. But I think you made a great point in regards to I think we all feel comfortable with coming up with different stretches, different strengthening exercises, just overall exercise progression when it comes to muscle strains. I think the largest question that most people have, and especially the patient, is this okay to feel? What should I expect to feel in the first week out from that strain? Should it be high levels of pain, low levels of pain? What should that look like on a week-to-week basis? What should those patterns or trends be? Can I push through it? Do I need to avoid it? And that took me a long time to get comfortable with. And it's going to be a range that you're looking for, and you want to have guidelines. But it was something that oftentimes early in my career, patients would ask me questions, and I would be hesitant to give a very definitive answer because it's hard to articulate, yes, it can hurt, and yes, it can be productive at the same time. And it's that casual line of making sure that you are being therapeutic and that we're not going too far with some of our interventions. So, Bami, can you dive a little bit into just how this study was laid out and what they were really looking to find?
Yeah, so there's 2 big aims in the study. One of the aim was to compare the time from an acute hamstring injury to return to play clearance, and they use a standardized rehab protocol. So there is a pain-free group and a pain threshold group. I'll kind of dive more into that a little bit later. And then another aim, they want to compare isometric knee flexor strength, biceps femoris long head, fascicle length, fear movement, and re-injury occurrence at the 6-month follow-up between the pain-free and the pain threshold group. So the design of the study, it was a double-blind randomized controlled trial. They had 43 participants, 22 was in the pain threshold group, and 21 was in the pain-free group. So how they kind of divided this was the pain threshold was between a scale of 0 to 10, 10 being worst imaginable pain, 0 being no pain at all. The pain threshold group could only advance to the next rehab stage if they were within 4 out of 10 pain. The pain-free group, they could only advance to the next stage if there was 0 out of 10 pain. And then the inclusion criteria for these participants was men and women aged 18 to 40 years old. They had to have an acute onset of posterior thigh pain associated with a clear mechanism of injury, so like your sprinting, high speed, or your stretching injury. They have to be present for initial clinical assessment within 7 days of the injury. They have to have pain on palpation of the injured muscle and pain localized to the site of injury during isometric knee flexor contraction.
Good. So I like the design of the study. It seems like they did a good job of actually delineating, finding people who had acute hamstring strains and they were seeking care within a reasonable amount of time as well. And I think in the clinic, that's something that you don't always get the luxury of. Sometimes people have that acute injury and then they've got to jump through a few hoops in regards to maybe just insurance restrictions with having to see primary care and then an orthopedic and then obtaining a referral to get to PT. So you don't always have that luxury of seeing them in those early phases, or sometimes just logistical issues on the patient's end of being able to get in at a time that matches up for them. So I like how they standardized this to having the acute injury, and it was actually a definitive injury, and then getting in for the assessment within the first 7 days. I also like the criteria that they utilize too. It follows a very logical model with regards to having the range of motion, having the strength with the knee flexion indices, and then also I think an overlooked indicator with hamstring injuries is the tenderness to palpation. I think that is something, it can linger around. It has been shown even when people are demonstrating ideal range of motion, ideal strength, it does present as a risk factor for re-aggravation or re-injury. That has been shown in previous studies and guidelines. So I'm glad that they included that. And also just to remind people, it's okay to put your hands on patients. And I think that's something that we need to do in the profession, whether it's just education for them on the actual location of the injury, differentiating for them maybe what's the muscle belly versus the tendon versus insertion sites, where is the actual hamstring in the thigh. And it's funny, I can't say how many people I've had come in and say, oh, I pulled my hamstring, and they point to the front of their leg, or they point to high up in their back pocket area. And I think it's good just from a patient education standpoint as well. Bami, what did they actually find with this study? If you don't mind just diving into like what the actual results were, and then if you want to talk a little bit just on some of the conclusions that they came to, and if you want to elaborate on your end at all as well.
Sure. So what they found was that the biceps femoris long head fascicle length, it increased in the pain threshold group more than the pain-free group from the initial evaluation to 2 months follow-up. They also found that from the initial evaluation to return to play, the isometric knee flexor strength increased more in the pain threshold than the pain-free group. The pain-free group average return to play was within 15 days. The pain threshold group average return to play was 17 days. And then when they looked at the re-injury, 2 participants in each group had a re-injury. In the pain threshold group, it came 8 and 17 days after the initial injury. And then in the pain-free group, it came 13 and 26 days after the initial injury. So ultimately what this article concluded was that pain threshold rehabilitation didn't necessarily accelerate return to play clearance, but resulted in a greater recovery for isometric knee flexor strength and better maintenance of the biceps femoris long head fascicle length improvements compared to the pain-free rehab group. They also concluded that pain threshold rehabilitation didn't really cause any adverse events. So for us, we're knowing that if we're kind of pushing our patients even past the point of pain, it's not going to necessarily cause any adverse events based off this article. And then lastly, they found that early introduction and progression of exercises will help emphasize eccentric knee flexor strength and hip extensor strength at moderate to long muscle lengths. So after reading this article, I think for clinical practice, it kind of shows that like avoiding pain during rehab isn't always necessary, right? So we could start to push our patients past that point of pain in like a stepwise manner. And we think about hamstring strain injuries, right? Hamstring predominantly acts in the sagittal plane, but it's okay to start to add in some things that's not going to lengthen the hamstring too much, right? So if someone just comes in with a hamstring strain, you want to get them doing some locomotor stuff, probably not going to have them doing any high sprinting, but maybe start to work in this frontal plane a little bit, right? So side marches where the hamstring isn't over lengthened. And then also, too, thinking about there is validity to starting rehab exercise earlier on, right, instead of just waiting past the pain. So we could start early and we could perform within like a pain threshold group. So if they're kind of staying within that, 4 to 5 pain range, based on the article, it's not going to do any further damage to that hamstring injury, to that hamstring.
You hit on a variety of touch points there that I think you did a great job of highlighting the importance of them. And one very important one was early on, you had mentioned that the pain threshold and the pain-free group, neither one really accelerated the rehab process, but the pain threshold approach was not detrimental to the process either. And I think we often look at what is the best possible case scenario for our patients and what gets the best outcome, what gets them back to the highest level of performance in the quickest amount of time. I think we also need to look at the back end. What is the worst possible scenario? And I think oftentimes we've avoided the pain threshold approach because we've been worried it may produce the worst possible scenario of a re-aggravation, of even further damage to the area. And I think this article helps to show that we can proceed with more confidence knowing that even if they're experiencing a little bit of discomfort, we're not having something detrimental to their outcome or that's going to have them go in the opposite direction. So I think we've all also encountered that patient that is just a little bit more sensitive and they have a higher pain sensitivity. And this just gives a little bit more validation to conversations you have with them in regards to it's okay to start PT. We don't need to wait 1, 2, 3 weeks out to start pushing exercise to be pain-free because we know that operating through a little bit of pain, they had mentioned kind of that 4 out of 10 pain threshold is appropriate. It's not detrimental and it's still going to allow you to achieve your outcome. So I think if anything, it safeguards you against worrying about the worst case scenario and also can allow you to just validate some of the patient's concerns for them.
Yeah, Zach, and another cool thing about the article was I think some clinicians, we sometimes fear, okay, if we get them back too early, what is the risk of them re-injuring themselves? And based off this article, right, 2 participants in each group had the same kind of re-injury rate. So it wasn't that the pain threshold group caused more re-injury than the pain-free group. So that was another important part of this article that I found was pretty cool.
The other thing that you had mentioned was hamstrings primarily function in the sagittal plane. And we may be more sensitive in the sagittal plane with a hamstring strain. But there's a lot of movements that the hip will go through that the hamstring does not need to be stressed with. And you had talked about maybe we do some frontal plane or some more transverse rotational work. And that's a way to get them moving with different locomotive and plyometric drills to maintain conditioning levels, maintain athletic qualities, but at a lower likelihood of aggravating that hamstring. And I think when we even go into our sagittal plane activities, we can modify range of motion. We can do skipping, we can do running, we can do things with potentially just a lower heel recovery where we're not getting as high of a thigh drive or as high of a heel recovery. We're not stressing that hamstring quite as much. So I think you did a nice job of just talking about some workarounds early on in the rehab where maybe we're focusing on some isolated hamstring isometrics, just to get tissue tolerance, to reactivate that hamstring muscle, build strength. But then we're utilizing other planes of motions to maximize physical qualities that are not going to agitate that hamstring as well. I think last thing to kind of touch on with this is the importance of utilization of BFR as well. And if you have somebody that does have a little bit of sensitivity early on in the rehab process, we may not be able to directly load that hamstring with great confidence or with great resistance without pushing them beyond that pain threshold. BFR is kind of that cheat code that you have that you can do your localized hamstring strength with as you're doing some of the other activities involving adjacent body parts or other planes of motion. And I think the BFR has obviously been proven to increase muscle strength, muscle size, and because we're not mechanically loading that muscle, we're not getting as much of the wear and tear on it with the exercise as well. So, Bami, I appreciate you picking this article. I think in our world, hamstring strains are very prevalent. Most of the individuals, whether it's youth, adolescent, high school, adult, are going to experience hamstring strain to some degree in the future. And hopefully this provides a little bit more clarity as to what that looks like. So Bami, I appreciate your time and your efforts with this. Make sure you stay tuned next month to hear Bami as we tackle the spine. And I don't know if he's going to go low back or cervical or thoracic spine with that, but we will have a midline injury that we're going to go with. So thank you, Bami.
Thanks, Zach.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.